So the next topic in this series is vascular neurosurgery. In this topic, we will know about commonly asked vascular disorders of the brain. So let's proceed with it. So first, talking about the brain AVMs, that is brain arteriovenous malformations. What are they, and what do you need to know about them? How do you treat them? So let's go ahead. So arteriovenous malformation, as the name is obvious, is the abnormal collection of the blood vessels, wherein the arterial blood flow is directly to the veins without any intervening capillaries. So there are no capillaries in between. Straight away the artery is draining into the vein. So this is what is arteriovenous malformation of the brain. So you can see in this post-mortem picture, where this side is the normal brain. On this side you can see multiple blood vessels, and these blood vessels are not appearing normal. So we'll go ahead and know more about the structure of the arteriovenous malformation of the brain. So typically they are congenital lesions, and they start with a very small area where the artery is straight away joining the vein, but initially they are low flow, and gradually as the child grows they become high flow, and that's why the common age of presentation is in young adults. And they tend to enlarge with age, and so they tend to recruit new vascular supply. And the presentation usually is as a hemorrhage. Either they will present with a bleed, and patient will have sudden onset headache and any neurological deficits, vomiting. And second type of presentation is due to the ischemia of the brain due to steel phenomenon. So what they will do is, because of the decreased resistance of blood flow, because straight away artery is draining into a vein, the blood flow inside the AVM will be increased. So what it will do is, the blood from the adjacent areas will preferentially go towards the AVM, and that will cause steel phenomena. So the vascular supply of the nearby areas will be stolen towards the AVM. So that's why the nearby eloquent areas, they will develop ischemic changes, and they will develop neurological signs. And another common way of presentation of AVMs is by seizures. So again, because of the redistribution of the blood supply, they will cause seizures, which can be intractable, which can be untreatable seizures. Now, what is the risk of AVMs? Why should we treat AVMs? So you should know risk of rupture of AVM and risk of bleed inside the AVM. It is about 4% per year. So next we will study about the structure of a AVM. So AVM is composed of feeding arteries, and then there is nidus. Nidus is the abnormal blood vessels. Nidus is the tuft of abnormal blood vessels of varying size, shape and compactness, and they are these abnormal vessels. And then in between you have gliotic parenchyma. So gliotic parenchyma is the parenchyma which is having glial cells, that is the supportive neural cells, but no neurons. So it is not eloquent, it is not functionally active area. So it is non-functional area which is intervening inside the abnormal tuft of blood vessels. And then finally there is a set of draining veins. So you can see over here a set of draining veins are there. So these draining veins either can drain into the deep circulation, or it can drain into the superficial circulation. So this property, whether it is superficial draining veins or deep draining veins, has a prognostic significance. We'll study more about it in the coming slides. So sometimes if there are high flow abnormalities, high flow AVM is there, it can also be associated with aneurysms in the feeding artery. So in the feeding arteries, because the blood flow is very fast, so they tend to develop aneurysms also. So all these things have to be noted when you are seeing AVM related CT angiography or DSA, cerebral DSA, digital subtraction angiogram of the brain. So in the angiogram of the AVM, you need to notice the supplying artery and the draining vein along with the nidus, and also if there are any aneurysms in the course. So these all you need to look at. Now you can see over here a picture of AVM. You can see abnormal veins and abnormal arteries, and here is the AVM. This whole area is the AVM, and over here is the normal brain tissue. So that's how the AVM actually appears like. And as I told you, the presentation is with headache, neurological deficit and seizures. And investigations, the most common are CT and MRI angiography, and DSA also is done. So treatment options are either you will do a craniotomy and excise the AVM if it is easily approachable. If it is deep located, so other options can be considered like embolization via intravenous catheter and stereotactic radiosurgery. By radiation you can give SRS, so gamma knife or cyber knife radiation you can give. So these are the ways by which you can treat the AVMs. So next, this figure shows the MRI, T2 weighted MRI showing the AVM. So all the blood vessels, abnormal blood vessels, are appearing as flow voids. So these black areas in the white background are called as flow voids. So this is the typical description keyword. This flow void keyword is used to describe any blood vessel on an MRI. So blood vessel appear as flow voids. So you can see multiple abnormal flow voids in the occipital region, of the brain in the T2 MRI. And similarly, you can see a tuft of abnormal blood vessels on the cerebral DSA in this picture. And in figure A, you can see a CT angiogram 3D reconstruction showing abnormal tuft of blood vessels. Now, how would you prognostically grade AVMs and how will you decide upon the treatment? So for this, Spätzler-Martin came out with a grading scale. So what is Spätzler-Martin grading scale? So it is a grading scale for AVMs, and you divide the AVMs based on their size and where they are located, whether they are located in a eloquent cortex, eloquent area, that is a functional area, or they are located on a non-eloquent area or a non-functional area. So based on that you will grade that. And next you will grade based on the draining veins, if the draining veins are superficial or they are the deep draining veins. So based on that you will give points. If the AVM is small, that is less than 3 centimeter, it will be given 1 point. If the AVM is medium in size, that is 3 to 6 centimeter, you will give it 2 points. And if the AVM is large, that is more than 6 centimeter, you will give it 3 points. And if it is located in a non-eloquent area, you will give it 0 point. And if it is located in an eloquent area, you will give it 1 point. So what is an eloquent area? Any area whereby if there is any lesion, you will see the difference. You will see either that particular body part will stop functioning, or you will have some sensory abnormality, or you will have a bowel bladder abnormality. So all those areas are called as eloquent area. So if AVM is located in an eloquent area, you will give it 1 point. Then venous drainage, whether it is superficial or deep. If it is superficial venous drainage, you will give it 0 point, and if it is deep venous drainage, you will give it 1 point. And then you will add all these points, and based on that you will decide upon the treatment and the grade of the AVM. Now next we will be talking about cavernous malformations. What are cavernous malformations? So cavernous malformation are typically low flow lesions, and they are well circumscribed benign vascular lesions. They don't have much of blood flow. They consist of irregular thin walled sinusoidal vascular channels. They lack any intervening neural parenchyma. They don't have any neural gliotic tissue or parenchyma in between. They don't have any large feeding arteries or any large draining veins. They have smaller feeding vessels only. So that's why they are low pressure and low flow lesions. So there is very less amount of flow. So that's why they don't appear in angiography. So even if you do a DSA, they won't appear in that. So they are angiographically occult. Now in these, the hemorrhage so in these cavernous malformation, the hemorrhage is typically not catastrophic. It will not lead to death, or it will not lead to severe mass effects. It is usually chronic hemorrhage which keeps on happening slowly. So their mode of presentation is usually headaches, seizures, and focal neurological deficits depending on the area where they are located. And MRI is the imaging modality of choice for diagnosis of cavernous malformations, and they characteristically have a hemosiderin ring. So that is the dark ring around these cavernous malformation which indicate chronic slow hemorrhages which are happening. So that's why there is a formation of dark area around the lesion, that is called as hemosiderin ring. And the typical appearance of cavernous malformation is described as popcorn appearance. So popcorn appearance is also a classical feature of cavernous malformation. And what is the treatment? So treatment is based on their size and the neurological deficit. So if they are presenting with recurrent intractable seizures and neurological deficit, then only you will excise them surgically. Otherwise, if they are not causing any problem, no neurological symptoms, then you can also observe them and do no treatment actively, or any surgical treatment you may avoid. Next, we'll be talking about brain aneurysms. Now, what are the types of brain aneurysms? So depending on the shape and the etiology, they can be classified into different types. So as you can see, this is the healthy blood vessel which has intima, media, and adventitia as its layers. And if there is a bulge in one particular wall of the blood vessels, that is called as saccular aneurysms. So if the wall of a blood vessel in a particular area is circumferentially dilated, that is called as fusiform aneurysm. What is a dissecting aneurysm? Is that the intima is torn and the blood makes its way through the media and adventitia of the blood vessel and start flowing through a abnormal route. So that is called as dissection of the artery, and the aneurysm and dilatation thus formed is called as dissection aneurysm. And there is also something called as false aneurysm, whereby the outer walls of aneurysms are not formed by the walls of the vessels but are formed by the scar tissue. So this is called as false aneurysms. So scar tissue and connective tissue of the outside forms the walls, and this is called as false aneurysm. And then there are infectious aneurysms which are also called as mycotic aneurysms. So mycotic aneurysms are typically multiple in number and they are distal in circulation. So they are typically found distally, and in that the whole wall of the blood vessel is disintegrated due to the infectious inflammation, and thus they are called as mycotic aneurysm. So mycotic aneurysms are caused most commonly by bacterial infections. As the name suggests that mycotic, you might think of fungal, but the most common cause of mycotic aneurysms is bacterial infections. Now saccular aneurysms are also called as berry aneurysms, and they present with rupture and subarachnoid hemorrhage. So in this CT scan you can see this hyperdense hemorrhage around the brain stem and in all the cisterns of the brain. So this is called as subarachnoid hemorrhage. And the rupture of aneurysm, the classical description is that the patient will present with sudden onset severe headache, and he will describe it as worst headache of my life. And usually subarachnoid hemorrhages are very critical, and 10 to 15% of patients with subarachnoid hemorrhage from subsaccular aneurysms are fatal before even the patient could reach the hospital. And of those individuals that reach the hospital, 1/3 of them will not survive. and one third who will survive, they will have some disabilities, and only one third will return to their baseline levels. So it is like one third principle in this subarachnoid hemorrhage and rupture of sacral aneurysms. So we'll repeat again. 10 to 15% of subarachnoid hemorrhage will not even reach the hospital, and they will be fatal even before that. And one third individual who reach the medical facility will not survive, and one third who survive will have some or the other neurological deficit, and only one third of these people will actually reach the baseline level. So what are the complications of subarachnoid hemorrhage? So it is either rebleeding can happen, again the aneurysm can rupture, then patient can have hydrocephalus because the blood in the cisterns will obstruct the CSF absorption, and that will lead to hydrocephalus, and it is seen in 15 to 20% of these cases. Then patient can also have concomitant cardiac complications and myocardial infarction in case of subarachnoid hemorrhage. So cardiac events are seen in around 50% of the patients. Then they can have vasospasm, hyponatremia and seizure. So these are all complications which are associated with a subarachnoid hemorrhage. So next we will be talking about the risk of rupture. So what aneurysms you can manage conservatively, and for what aneurysms a surgical or a endovascular treatment is mandatory. So that depends on the area where the aneurysm is located. So if it is an anterior circulation aneurysm and if it is less than 7 mm in size, you can manage it conservatively. And if anterior circulation aneurysm is more than 7 mm in size, that you will have to manage either by a surgical route or by endovascular route. If the aneurysm is in posterior circulation, so aneurysms of posterior circulation, even if they are less than 7 mm in size, they can rupture. So the 5-year risk of rupture is 2.5%. Similarly, if the aneurysm is located in cavernous part of the carotid artery, so those aneurysms, if they are less than 13 mm in size, you can manage them conservatively. If they are more than 13 mm in size, they require surgical management or endovascular management. So this table from Sebastian explains this. If the carotid cavernous aneurysms, if they are more than 13 mm in size, they have a risk of rupture. So you have to manage them either surgically or endovascular route. If the anterior circulation aneurysms are there, if they are less than 7 mm in size, the risk of rupture is 0. If they are less than 7 mm in size but there has been a prior SAH, the risk of rupture is 1.5%. And if they are more than 7 mm in size, then the risk of rupture is high. For posterior circulation aneurysms, if they are 7 mm in size, even if there has been no prior bleeds, they can still rupture. So all posterior circulation aneurysms should be managed. Now talking about hydrocephalus in case of subarachnoid hemorrhage. So as you know that subarachnoid hemorrhage will lead to dysfunction of absorption of CSF, and there will be collection of CSF in the ventricle. So you can see in the CT scan the ventricle temporal horns are appearing dilated. So in these cases, how will you manage? In these cases, you may need to drain the CSF because the CSF is not getting absorbed properly. So either you will put a external ventricular drain, or you can put a Mooyamaya reservoir to drain out the CSF. Now talking about vasospasm. So vasospasm appears when there is subarachnoid hemorrhage. So it is seen usually on 7 to 14 day after the subarachnoid hemorrhage. And what is vasospasm? As the term is quite self-explanatory, that it is narrowing of the cerebral arteries and it is caused by smooth muscle dysfunction. So the blood vessel has certain smooth muscle which are responsible for vasodilatation and vasoconstriction. So those muscle go in dysfunction because of the break down products of the blood which are toxic for these muscles. So they will go in vasoconstriction, and that will lead to vasospasm, and it will lead to decreased blood supply to the brain. So this is called as vasospasm. How would you treat vasospasm? So there are three main modalities. First is you will prevent the arterial narrowing, then you will have to reverse the arterial narrowing, and you will have to prevent and reverse the ischemic neurological deficit. So in prevention of arterial narrowing, you will have to first remove the subarachnoid blood either by lumbar drainage or by EVD drainage. You have to prevent the dehydration and hypotension. So the blood volume which is being supplied to the brain should be increased. So blood should be euvolumic, and hypotension should be prevented. Then you can start calcium channel blockers like nimodipine. So they are protective for the neurons, and also will prevent the vasoconstriction. Then reversal of arterial narrowing, that you can again give either intra-arterial calcium channel blockers. So you can by endovascular route give intra-arterial nimodipine, or you can also do transluminal balloon angioplasty by endovascular route, and you can reverse the ischemic neurological deficit by maintaining optimum circulation, by maintaining a slightly hypertensive environment with hypervolemia and hemodilution. So this will ensure that there is good supply to the ischemic areas of the brain, and then there is also good oxygen delivery. So next, about the grading of subarachnoid hemorrhage. So how would you prognosticate a patient with subarachnoid hemorrhage when he has first come to you, based upon his clinical condition and based upon his CT scan? So for this prognostication, there has been a lot of scales which have been developed to prognosticate and grade the subarachnoid hemorrhage. So first most important scale to grade subarachnoid hemorrhage is the Hunt and Hess clinical grading scale. So Hunt and Hess grading scale is a clinical scale whereby you grade the subarachnoid hemorrhage patient with based on his clinical parameters. So if the patient is coming to you and he is asymptomatic, or if he is having minimal headache and only slight nuchal rigidity, so that patient will be a grade 1 Hunt and Hess scale, and in that patient the outcomes are good, up to 70% good outcomes. Then next, if the patient is having moderate to severe headache and he is having nuchal rigidity along with any cranial nerve palsies, so that also the grade will be 2, and it will have good outcome up to 70%. If the patient comes to you and he is drowsy, confused, and he is also having mild focal deficit, either some weakness in hand or speech problems, so that patient will be graded as grade 3 Hunt and Hess. The probability of good outcome is 15% only. If the patient comes to you with stupor, moderate to severe hemiparesis, and decerebrate rigidity, and the patient is M2, motor response is M2, so those patient will be graded as grade 4, and good outcome probability is only 15%. If the patient comes with deep coma, decerebrate rigidity, and moribund appearance, so that will be graded as grade 5, and the good outcome probability is 0. So what is another clinical grading scale? It is WFNS grading scale, and there is one CT scan based grading which is called as Fisher grading scale. So this is the WFNS grading scale which grades based on the GCS score. So if GCS is 15, that and the patient is having no motor deficit, he will be graded as grade 1. If the GCS is 13 to 14 and there is no motor deficit, patient will be graded as grade 2. If the GCS is 13 or 14 and the motor deficit is present, then the patient will be graded as grade 3. If GCS is poor, that is GCS is 7 to 12, whether or without motor deficit, the patient will be graded as grade 4. And if GCS is indicative of severe deterioration, So if the GCS is between 3 to 6, the patient will be graded as grade 5, irrespective of the motor deficit. So this is the WFNS neurological scale for SAH patients, which is based on the GCS score. Then talking about the Fisher grading appearance based on the CT appearance of the subarachnoid hemorrhage. So if there is no hemorrhage which is evident, it is called as grade 1. If there is diffuse SAH and there are vertical layers of blood which are less than 1 mm thick, it is graded as grade 2. If there are localized clots and vertical layer of SAH which are more than 1 mm thick, that is graded as grade 3. And if there are diffuse or no SAH but with intracerebral and intraventricular hemorrhage, so that is graded as grade 4. So this is the Fisher grading scale, which is based on the CT scan findings. Now, how will you treat these secular aneurysms who have presented with subarachnoid hemorrhage? So the treatment options are either by surgical clipping, where you will put a titanium clip over the neck of the aneurysm. You can do coiling through via the endovascular route. You can put coils and obliterate the aneurysm from inside, so that no further blood will flow inside the aneurysm and it will be obliterated from the circulation, and the risk of rupture and blood leak from the aneurysms will go down. You can do coiling with support of the stent. So if the aneurysm neck is wide and there is a risk of coils getting delodged from the aneurysm, so you can do it with the help of a stent. So stent assisted coiling you can do. Then you can put a flow diverter. So in case the aneurysm is very closely associated with a branch which can lead to further neurological deficit, so to preserve that branch, you can put a flow diverter implant. So this flow diverter will selectively block the aneurysm and allow the blood flow through the perforator or through the branch you want to preserve. And as you know, in case you want to put a clip, you will have to do a open craniotomy and clipping. So these days, earlier clipping used to be the first choice, but with advent of endovascular route, these days they try to manage most of the aneurysms via endovascular route, and if they are not able to manage, only then surgical route is tried upon. Now, open craniotomy and clipping is now typically reserved for those lesions believed not to be amenable for endovascular techniques, and treatment of ruptured aneurysms is best accomplished as soon as possible after the initial hemorrhage. So, if an aneurysm has bled one time, immediately then and there you have to do the management for the treatment of aneurysm, so that it should not rupture again and should not cause risk to life. So next we'll be talking about spontaneous intracerebral hemorrhage. So spontaneous intracerebral hemorrhage is seen in 10% of all the strokes. And why does spontaneous intracerebral hemorrhage happen is usually seen in chronic hypertensives and older patients, and that happens due to the degenerative changes because of this hypertension. What are these degenerative changes? What happens is, in chronic hypertension, the small perforating blood vessels, they will develop something called as degenerative aneurysms, very small aneurysms, which are called as Charcot-Bouchard aneurysms of the perforating vessels. And these perforating vessels will rupture because of the persistent hypertension. And most commonly, these perforating vessels which rupture and cause spontaneous intracerebral hemorrhage are the lenticulostriate vessels, which commonly supply the basal ganglia. So spontaneous intracerebral hemorrhage most commonly is seen in the basal ganglia or the BG bleed. So BG bleed is the most common spontaneous intracerebral hemorrhage, which is due to the Charcot-Bouchard aneurysms. Now, the clinical presentation is that the patient will have sudden onset focal neurological deficit. That means either he will have sudden onset weakness of half of the body, and he will also have headache, vomiting. He can have deteriorating consciousness, altered sensorium. So depending on the side of the hematoma, they will have these symptoms. And what is the treatment? So if there is not much of mass effect, there is only a small bleed, you can manage these patient conservatively by controlling the hypertension and giving anti-edema measures. And in case the size is quite big and it is and there is a risk of herniation, brain herniation, then you can operate and evacuate the hematoma. So depends on the presentation and the size of hemorrhage which is there, and what is the level of edema and mass effect by this hemorrhage. Depending on that, you will do the treatment. So next we'll be talking about mycotic aneurysms. So mycotic aneurysms are the aneurysms which are due to the infective causes. So any systemic infection which result in showering of small bacterial particles, and they will come to the vascular bed in the distal arteries, where they will start their vasculitis changes and damage the vessel walls, and this will cause vessel wall dilatation, and that are called as mycotic aneurysm. So where are mycotic aneurysms seen most commonly? It is either in subacute bacterial endocarditis and pulmonary infections. And from these areas, either from the heart valve which is infected, or from pulmonary infections like lung abscess, there will be bacterial emboli which will lodge to the distal cerebral arterial branches, and they will start eroding the vessel wall, which will lead to formation of these aneurysms. So what is the distinguishing features of the mycotic aneurysms compared to other saccular aneurysms? So they are found more distal in the vascular bed, and usually they are multiple. So you can see it is in the distal cortex, this particular aneurysm. So they are seen in more distal vascular bed, and they are multiple. And what is the treatment of choice for these aneurysms? It is antibiotics. So antibiotics is the most important treatment of choice, because usually these aneurysms are small and they are fragile. So if you try to clip them or manage them endovascularly, that will cause further rupture of these aneurysms. So you have to start antibiotic therapy to stop the bacterial multiplication and further damage to the vessel wall. So that is the treatment of choice of mycotic aneurysms. Now talking about Mooyamaya disease. What is Mooyamaya disease? It is another vascular disorder which leads to gradual obstruction of medium to small size blood vessels in the brain, and it is a idiopathic disease. The cause is not known, the pathophysiology is not clearly understood, and it is a non-atherosclerotic narrowing and occlusion. So there is no role of atherosclerosis in the occlusion of these blood vessels. It is due to the inflammation. Actually, these blood vessels get obstructed. So you can see this is the normal artery, and this over here is a Mooyamaya disease artery, where you can see the lumen is getting narrowed and gradually it gets obstructed. So once the vessel is obstructed, what it will happen is that there will be a development of compensatory collateral vessels, compensatory collateral reti vessels, which will get developed, and it will allow continued cerebral perfusion around the occluded vessel. So these tuft of vessels which are there, which are newly regenerated blood vessels, they will appear as a tuft of smoke. So that's why this disease is called as Mooyamaya disease, which in Japanese means puff of smoke. And usually this Mooyamaya disease is bilateral, and in angiography you will see severe narrowing of ICA, that is internal carotid artery, MCA and ACA, or its occlusion. And then there will be multiple clusters of fine collateral reti vessels, fine collateral newly formed vessels, which will appear like a puff of smoke, and these are very fragile, and that's why these Mooyamaya disease patient will present with both ischemic like symptoms, and they can also present with hemorrhagic symptoms, where the blood vessel, because it is very fragile newly formed blood vessels, so they can cause hemorrhages also. So in the adult form, this Mooyamaya disease will have subarachnoid or basal ganglia hemorrhages. So you can see in this DSA there is further obstruction of the ICA, and you cannot see the MCA arteries, M1 segment you cannot see, but you can see multiple thin blood vessels like appearing like smoke, which are maintaining the distal circulation. So this is a leash of Mooyamaya vessels which is replacing the right suprahialar carotid artery. So over here you can see further circulation, but it is via the fine blood vessels. So these fine blood vessels, they can lead to ischemic changes in the cerebrum, and they can also rupture and cause hemorrhages. So adult form there will be hemorrhages, and in pediatric form there will be more of ischemic predominant features. Now what is the treatment? So surgical treatment will consist of extracranial intracranial bypass. So typically what you will do is superficial temporal artery, you will bypass to the middle cerebral artery. So from ECA circulation you will bypass to the internal circulation of the brain, so that the blood supply to the brain is maintained, and this kind of management is preferred in adults. And in case of children, you will prefer only synangiosis. That means you will you will not do the bypass, but you will put a blood vessel over the brain surface, and it will gradually uptake, form new branches to supply the brain surface. So this is called as only synangiosis. So this was all about vascular neurosurgery we needed to discuss for your purpose at your level. And if you have any doubts, you can post to us. Thanks a lot for patient listening.